future drug development of active agents in a later line setting will focus on two things. Number one, really identifying patients, subgroups, molecularly defined subgroups for targeted intervention. I'm looking at low frequency mutations and alterations like BRCA mutations, like PALP2 mutations, which do exist in colorectal cancer, but at lower frequency, for instance, than in pancreas cancer, prostate cancer, and breast cancer. I'm looking at other alterations like fusions, RET alterations, etc. So everything that we know from other tumors should be tested also in colorectal cancer. And even if we just identify, let's say, 2 to 5% of patients with these selected mutations that are targetable, it helps these 2 to 5% of patients. That's one thing. Then the other point is, of course, we want immunotherapy to work, because immunotherapy is a very powerful tool that can lead to sustained responses, really affect the clinical course of patients dramatically. And I strongly believe that further insights into immune escape mechanisms, immune suppressive effects of cancers, we will find combination therapies, clearly not single agent, but combination therapies that will augment immune responses, will make immune therapy work in MSS colon cancer. So there's not one agent that I would single out right now, but that's the road forward. There are dozens and dozens of trials ongoing right now, and this shows me with various combinations, shows me no one knows exactly the right answer, because preclinical models are not perfectly predictive what's happening in a host like a human body in terms of immunotherapy. But I've not given up my hope.
I'm very excited about the future, because I think we have just started to take advantage of the newest molecular technology profiling platforms such as NGS. We will identify more and more very unique targets and may potentially fragment out more and more colon cancer, which we have started with the BRAF, we have started with MSI, we have started with KRAS. I think that will expand. And I think one of the major new strategies is that we are so focused on one single mutation, KRAS, BRAF, whatever, PI3 kinase or P53. We have not even learned to understand what does it mean when you have a KRAS and a P53 mutation. Does that change the efficacy of certain targeted drugs? So I think we are just on the beginning to understand the complexity of genetic signatures, because we have been just stuck to one mutation to the other and have not moved on to that. I think machine learning, artificial intelligence will help us to understand it. So I'm very excited about that. I think that there is a lot of new drugs coming, and the challenge will be, how can we select the patients? I think this molecular profiling technologies developing are very helpful. I'm also very excited about the use of the liquid biopsies to really monitor in real time molecular changes, identifying novel targets, and potentially use better treatments, taking advantage of the activated mechanism-resistant pathway you see in the liquid biopsy. So I'm very optimistic. I'm sure we will push further the limit and increase overall survival for our patients. I think that we will solve in the next couple of years the KRAS mutant population. We have SOS inhibitor, we have certain vaccines, we have certain polokinase inhibitors, which seem to be promising in a subset of KRAS mutant. So I'm very hopeful that this will move forward and that we finally have a more effective treatment for KRAS mutant. I think that with the deeper understanding of immune signaling, we will get better immunotherapy combinations. And we have now more sophisticated vaccines. There is the entrance of oncolytic viruses. So I'm very optimistic that we will also make significant progress for the MSS patients who at the moment are very limited to use clinical trials with immunotherapy combinations.
Clearly, we have done a very important series of steps forward, a better prognosis deriving from a better management of metastatic colorectal cancer. I say that 20 years ago, we had very few drugs, and the expected median survival was between 6 and 12 months for most patients. Now we are extended 3 or 4 times this expected survival time for most patients. What we need to do is to understand more and more the tumor heterogeneity of metastatic colorectal cancer. We need to apply more and more chemotherapy combinations, sequencing of therapy in different lines of treatment, re-challenge with specific drugs, biologic agents against specific molecular targets, and immunotherapy in a more and more selected way. So basically, the big challenge in the treatment of metastatic colorectal cancer is to apply the enormous knowledge that we are accruing more and more on the genetics and epigenetics of this cancer at individual patient level, that can be followed during evolution of disease by liquid biopsy testing. All this information is a big challenge because this should be applied to select the specific therapies that are on individual basis. And so the big challenge is really to apply precision medicine in the treatment of metastatic colorectal